important joint in the body, the wrist joint. Fractures around it. The wrist joint is very important in that any problem with the wrist, everybody notices. If there is a wrist fracture which was not managed properly, then patient will have pain, patient will have swelling, deformity, and everybody can notice it and comment on it. So for the patient also, any residual deformity and pain in the wrist joint will not allow him to use the hand most effectively, thereby he will be cursing the doctor who has treated it. So from the doctor's point of view, as well as from the patient's point of view, this joint is a very important joint, and we all should know what are the fractures which can occur in and around the wrist joint and how to manage them in a proper way. Coming to a wrist joint, the synovial joint, the articulating surfaces are the distal end of the radius and the proximal carpal bones, proximal row of the carpal bones, except pisiform. So fractures of the distal radius, they come in different types, different shapes, different sizes, and among them, Colles fracture is the most important one because it's the most common fracture, and it's a common fracture which is mismanaged and which will lead to a lot of malunions and a lot of deformities around the wrist joint. Because usually whenever there is a fracture in the wrist joint, most often the patients will not come to you in the first place. They go to the neighborhood bone setter where a lot of damage can be done, and they come to you, they end up in your clinic with a lot of complications. So you should know everything about fractures of the distal radius. Here, as I told you, the common one is Colles fracture. Colles fracture is the lower end fracture of the radius without extending into the articular surface. So the fracture line starts here and it may enter the articular joint. It may be intra-articular, may not be intra-articular. And the main problem here is the distal fragment goes dorsally, back of the wrist. So if the deformity is onto the back of the wrist, dorsally, then this is called Colles fracture. And if it comes ventrally or anteriorly, then it is called Smith's fracture. That's why people commonly say that Smith's fracture is opposite to Colles fracture. It is opposite only in the extent that the distal fragment goes onto the other side rather than the dorsal side as in Colles fracture. So Colles fracture, it goes dorsally. Smith's fracture, it goes ventrally or anteriorly. There is another type of fracture, it's called a Barton's fracture. In Barton's fracture, the fracture is only a part of the articulating surface. In the part of the articulating surface, one half, this is one half and this is another half. And if the half involves the dorsal fragment and angulates dorsally, that is called a dorsal Barton's fracture. If the fragment is on the ventral side, then it is called a ventral Barton's fracture. So basically, there are four types of fractures, important ones. One is the Colles fracture, another one is Smith's fracture, dorsal Barton and volar Barton. And as we go along, we will see one or two other fractures, and all of them are very, very important because important complications in most of these fractures is stiffness, and a stiff wrist is useless wrist, and not only useless, it causes severe pain and it's a painful wrist, and there may be a malunion will lead to a deformed wrist, and there are other complications complications, definitely we will look into them later. And as for anything, all the fractures, you have a Friedman's classification for distal radial fractures. If you know the name, it's enough to clear the exams. But if you want to know everything about distal radial fractures, at least you should know what this Friedman's classification is all about. This is the radial classification based on the posterior view of the radius or the wrist fractures. So there are type 1 to type 8, and as a rule of thumb, the complications increase from type 1 to type 8, and the management differs from each and every type. The management becomes more and more complicated as you go along from 1 to 8. So coming to the main difference between Colles and Smith. So I keep on telling you several times during my lecture here because I want all of you to have a clear view what's a Colles fracture and what's a Smith fracture. So previously you have told you that it is a dorsal displacement in Colles fracture. Dorsal or outward. You can see the person is falling on the dorsiflex wrist, outstretched hand, that is force. Okay, dorsal displacement is Colles fracture. And here, when he is falling on the palmar flex wrist, you can observe the position of the wrist and the person is falling. So here, the wrist is flexed inward, that is palmar flexed. This is flexed outward or dorsiflex. That's why the fragment goes outward or dorsally in a Colles fracture, or inward and anteriorly or ventrally in Smith fracture. Okay, so same thing is repeated. Dorsal angulation, Colles, palmar angulation, Smith. Main mechanism of injury is fall or outstretched hand, that is otherwise known as force. So this is in summary about a Colles fracture. This slide, if you can remember this, even if it is an essay question, all of you can write this and come out with flying colors. That's why this slide is very colorful. I want all of you to come out with flying colors. So we added a lot of color in this slide. So Colles fracture, this is fall on outstretched hand. You can see here the hand is stretched out, and distal radial fractures with dorsal angulation, and sometimes there may be impaction. What is impaction we can see later, and most commonly seen in elderly women with osteoporotic bone, that is called postmenopausal osteoporosis. After menopause, the bones become soft because the effects of estrogen are lost in postmenopausal period. Then the bones become more osteoporotic, and even a low energy fall or a simple injury can lead to this type of deformity. All of you can see this fracture which is in the distal radius. The fragment is gone distally, and the deformity you can see from outside is akin to this implement which most of us use during our dinners. So this is dinner fork deformity. It doesn't mean that you cannot use it for lunch. Yeah, this is a dinner fork deformity that is seen in Colles fracture. And all of you know what Fuchs is. This is fall on outstretched hand. That is one of the most important mechanisms by which you can get a Colles fracture. And why it is named as Colles fracture? This gentleman is Abraham Colles, and he described this fracture in 1814, and this is his original paper in which he has published, and with a lot of difficulty I could get the photograph of this. So it's very rare, and I just wanted to show you the things which were there at that time. And he's a great man in that he could visualize what all happens in a Colles fracture, and his described in minute detail what happens in Colles fracture. Mind you, X-rays were not available at that time. X-rays were not invented till some more decades. But he was a genius and he was a pioneer in that he could describe all the deformities, all the angulations, all the displacements which occur in Colles fracture, and that's why he is great. And till today, even with our latest technology, all the radiology, all the CT with the 3D reconstruction and so many soft toys to play with, nobody could add or take out a single word from what he has described in April 1814. See, this is Edinburgh Medical Journal in which his paper was published initially. And if you go through that article, everything about Colles fracture is described there. And you cannot take out a single word from it or add to what he has written. So that is his greatness. And this is Abraham Colles. And there is an interesting anecdote regarding Abraham Colles' childhood. See, he was living near a place, near a doctor's house, and during floods in his town, doctor's possessions were washed away, and fortunately, most of his books were saved by Abraham Colles, and he has taken them to the doctor. And in gratitude, the doctor presented Colles with an anatomy textbook. And Colles was very much interested in anatomy after that, and he became a greatest anatomist, and he had a lot of credits. He invented so many things, like he devised so many procedures, and so many things were laid after him, like Colles fascia and Colles ligament. This inguinal ligament is otherwise known as Colles ligament. So he was a great anatomist, and that was a spark which was ignited by the doctor in Colles by presenting him by that anatomy textbook. So I expect most of you maybe a spark is ignited during your medical student days, and maybe you become greatest of physicians or surgeons, so that you can treat us when we are in need of that. So Colles fracture, all of you know, it's a distal radial end fracture which is 2.5 centimeters from the joint. Sometimes it doesn't mean that there may not be intra-articular extension. Definitely there may be intra-articular extension sometimes, and there may be fracture of the ulnar styloid as well, and more common in postmenopausal women. And this is the dinner fork deformity we were talking about. So these things should be imprinted in your minds. So whenever somebody says Colles fracture, dinner fork deformity, postmenopausal women, and Smith's fracture, which is opposite to Colles fracture, and Barton fracture, all these things should flash in your mind. Coming to the displacements, we all know that these displacements are spoken to in association with distal fragment. It is the distal fragment which is always displaced. So in Colles fracture, you have these displacements and angulations and rotations, and all of you should know these things. And there is no excuse. As I told you in the last class, there are some things in orthopedics and they are iconic. Like if you are staying in Mumbai, you need to know Malabar Hills, or where Shah Rukh Khan lives, or where Salman Khan lives. So similarly in orthopedics, you should be knowing about fracture neck of femur and Colles fracture. So anything about these fractures and iconic things, if you are unable to answer in the examinations, it shows you in very bad light. So coming to the displacements in Colles fracture, there is something called impact impaction. Here you can see the bony fragments are impacted into each other. So there is no displacement, but there is impaction. In these impactions, there will be some bit of stability, but you cannot take it for granted that this will be stable always. So it is better to fix these impacted fractures if possible, and there will be definitely shortening because the bones are impacted into each other. So the overall length of the bone may be reduced, but it will be short. So this is impaction here. And lateral displacement. The distal fragment is displaced laterally. So this displacement should always be corrected. If you don't correct this, then it will unite in this way only, and you will get that linear fork deformity as a yeah. Okay. Can you see the slides? One second. One second. We have some technical help. తీసి పెట్టుకున్నామని ఫెనాప్సిస్ సరిపోద్దా? Yeah, sorry about that. If the audio quality is good, yeah, please let me know. So here the impaction causes a bit of stability, but the length of the bone may be reduced. Coming to the dorsal displacement or lateral displacement, the bony fragment goes to the lateral aspect. Here you can see the bony fragment moving to the lateral side. So if you leave it like that without reduction, this may go into a malunion. Coming to the other deformity, there may be lateral angulation. So angulation, here there is angulation. See, this is tilted dorsally, or it's otherwise known as tilt, angulation or tilt. This is tilted laterally. You can see the tilting of the fragment here, and even this needs to be corrected, otherwise there will be a malunited Colles fracture. Coming to the dorsal displacement, all of us have seen that Colles fracture, there will be a dorsal displacement. So there may be a dorsal displacement, a dorsal tilt, a lateral displacement, and sometimes maybe dorsal rotation or tilt. So dorsal displacement, dorsal tilt, lateral displacement, lateral tilt or lateral rotation. Very easy for you to remember. And impaction. And there is another deformity which is known as supination. So the Colles fracture typically has an impaction, lateral displacement, lateral angulation, dorsal displacement, dorsal angulation, and supination. And clinically, when the patient presents himself to the casualty, the wrist will be like this. So the typical dinner fork deformity clinically you can see. Along with that, routine fracture signs and symptoms like pain, tenderness, deformity and swelling, all these things will be there, and history of trauma, and most commonly fall on the outstretched hand. And here, once you clinically examine, you should be very, very gentle, because we are pain reducers, we are not pain producers. So you should always remember this. So whenever a patient comes to you with acute condition, so you should be very, very gentle in your examination, and never try to elicit all the signs of fracture to satisfy your curiosity. Yeah, we all know that there should be a crepitus, there should be an abnormal mobility to diagnose a fracture. But that doesn't mean that in each and every fracture you try to elicit these things. See, with a history of fall and a deformity like this, you can easily make out a diagnosis of Colles fracture, and which can be easily proved with radiology. Okay, so while clinically examining, you can lightly touch and examine the styloid process of the ulna and the styloid processes of the radius. Usually the styloid process of the radius is much down, maybe around 1 centimeter distal to the styloid process of the ulna. So these are the bony points which everybody can easily feel underneath the skin. Subcutaneously you can easily feel from outside. This is a normal arrangement. But in Colles fracture, whenever there is a fracture in the distal end of the radius, you can all see the distal end of the radius, and there is some impaction, there is some shortening, and here you can see the levels of the styloid process. This is the styloid process of the radius, and this is the styloid process of the ulna. They are more or less are at the same level, and sometimes the styloid process of the radius may be much more proximal to the styloid process of the ulna. This all depends on the severity of the violence. If the energy is more, then maybe there will be more impaction or more displacement, more proximal migration, and it may lead to even the radial styloid going much more proximal to the ulnar styloid. So in a clinical setting, you need to see all these things. Clinically, once you see this and go for X-rays, X-rays will reveal the Colles fracture. So this is a radiological finding of a Colles fracture, and here you can find a ulnar styloid process fracture also. So sometimes ulnar styloid fracture is also associated with this, and sometimes the intra-articular extension of the fractures may also be clearly seen. A simple straightforward radiograph is all that is needed to diagnose a Colles fracture. But sometimes you are not sure about the associated injuries to the associated injuries to distal and radial fractures. Then there is a scope and indication for a CT scan. So you, just because you have a CT scan in your hospital, you should not send all the patients for CT scan, because the risk of radiation is always should lurk in your minds, because unnecessary risk of radiation to the patient should never be done. Okay, whenever there is an indication, then only you should subject the patient for CT scan. So what are the indications? Here this is a CT scan of the wrist joint with 3D reconstruction. So they have reconstructed what all is happening here. So these are all the diagrams. This is a diagrammatic 3D reconstruction. These are radiological findings here. Here you can see the comminution here, and the central fragment, there is a depression, and injury to the ulna is also clearly seen. So if you have these gadgets with you, and if you need them, then you can plan your treatment much better. So when do you indicate CT scan? The indications for CT, whenever you have intra-articular fractures with multiple fragments. So when there are multiple fragments, you should know where all the fragments are lying. Unless you know the fragments location, it will be very, very difficult for you to reconstruct the wrist joint. And if there is any centrally impacted fracture like this, then you need to bring it up. See, the joint line should be normal, smooth. If the joint line is not normal, even after your reduction, then there will be a step irregularity, and this irregularity may lead to what is known as secondary osteoarthritis, and it will result in a severe painful wrist with severe restriction of the movements of the wrist joint. So this is and one more indication is distal radio-ulnar joint incongruity. Along with wrist joint, there is one more joint at the distal radius. Distal radius articulates with distal part of the ulna. there is a joint here. It is called distal radio ulnar joint, and the congruity of the joint is also very, very important. So radiology may or may not show the incongruity always. So if you want to know whether if it is intact or not, then you need to resort to the CT scan with 3D reconstruction. Coming to the goals of treatment in every fracture, especially when it comes to an intra-articular fracture. Here, because the wrist and the hand functions are very, very essential. So if the wrist is stiff, even a supple hand cannot function to its full extent. 100% it will not. So our first and foremost goal should be to preserve the hand and wrist function and to realign normal osseous anatomy. As I have already mentioned, if the normal anatomy, especially the articular anatomy, if it is not maintained, then it may lead to step-offs and irregularities in the joint line, which may lead to early secondary osteoarthritis. And the bony union should be promoted. If you reduce it properly and immobilize it adequately, then the bone unites in its optimum position. So that is if you do the reduction properly and immobilize it properly, then you are promoting bony healing, and you can avoid complications by managing them in a proper way. And the dictum in orthopedics is the unaffected joints should always be mobilized, always. Okay? In a wrist fracture, the fingers are not involved and the elbow joint is not involved. So the fingers and elbow should always be mobile from day one. And these are some of the movements in the wrist joint. This is flexion, and this is otherwise known as palmar flexion. So because the hand is going towards the palm, so this is called palmar flexion, and extension is commonly known as dorsiflexion. Okay, because that is going towards the dorsal side, dorsiflexion. And this is radial deviation. Radial deviation, or some people may call it as abduction. This is the radius, this is thumb, and this is radius. This is the lateral side, this is the medial side, little finger and ulna. So this is ulnar deviation or adduction. But ulnar deviation is a proper word, and all of you can easily remember. And this is pronation and this is supination. All of you know pronation and supination. So these are some of the movements which are seen in association with the wrist joint. Coming to, there are two types of treatments in fracture distal end of the radius, especially the Colles fractures. So one is close reduction, another one is open reduction. Most of you know that surgical management and conservative management. Here most often we resort to what is known as a close reduction, and to keep the fragments stable, we may resort to plaster and sometimes we may pass some pins. Here, this is a typical technique for close reduction. We use anesthesia. As we have already seen, every fracture for reduction should need anesthesia because it is a very painful process, and we should not subject the patient to pain, and it may lead to sometimes a neurogenic shock. There is something called a hematoma block. That means whenever there is a fracture, there is hematoma. So in distal radial fractures also there is hematoma, and you inject the local anesthetic agent into the hematoma, thereby making that area anesthetic. So this is called a hematoma block. So you inject these your xylocaine or other local anesthetic agents into the hematoma, making it pain free and do the reduction. Or you can do what is known as intravenous sedation. Intravenous sedation, most of you know, this is a like general anesthesia, pentothal sodium and all. So you a patient will get analgesia, then you knock off the muscle relaxants, then put a endotracheal tube. So all these things, that is general anesthesia. There is something called a Bayer's block or intravenous anesthesia. Bayer's block is where regional anesthesia, it's a type of regional anesthesia where you tie two BP cuffs to the arm and you inject intravenously this local anesthetic xylocaine only, and you see to it that it won't go into the systemic circulation. It stays only at the area which is affected and you do your surgery. So this is called a Bayer's block. And you all know that there should be a traction and counter traction to reduce the fractures. And how you go about reduction, you need to hyperextend the distal fragment because it is dorsally displaced. Once you hyperextend, it will be free and you can put back in its normal position. And you should correct the radial tilt and then apply a well molded splint or cast. Usually what we do is, if there is lot of swelling, we usually put it in a slab, a well applied and tight slab, and in 2 days, once the edema comes down, we change it into below elbow POP cast with wrist in neutral to slight flexion. Then you need to do check x-rays to confirm the reduction, and if the reduction is acceptable and if it is stable, then you go for cast conversion. And every week you need to check the plaster, and if needed you need to get a check x-ray and see the reduction. And if the reduction is not acceptable, then you may have to redo the maneuver again. So we have seen this is the fracture, and the traction is being given in this direction and counter traction is like this, and correction of the tilt, dorsal tilt is being corrected from here and radial tilt is being corrected by this maneuver, and they put the plaster. So this is one of the latest plasters which we have in the market, and you can choose depending upon the dress you are wearing at the time of presentation into the OP. You do have colors. You have pink, blue, I think green, white also you can have, and this is how we give the hematoma block. So we inject this anesthetic agent at the site where the hematoma is there. You can see the deformity, and this is a fracture. And when do you resort for closed treatments? Closed treatment, low energy fractures and low demand patient, post-menopausal 70, 80, 90-year-old ladies, they don't need any energetic management with all their comorbidities present. In them, a bit of malunion may not do much harm, and we usually select this type of treatment for them. And if the minimally displaced, and if the displacement can be correctable, and if it is stable after correction, then we go for closed treatments. And this should be there for 6 weeks. And it doesn't mean that you should leave the patient for 6 weeks. Once you put this plaster, you ask the patient to come after 2 days. After 2 days, patient should report back to you, and you should clinically examine. You should satisfy yourself that there is no contraction of the structures because of the tight plaster. So once you examine that and ask them to keep the plaster properly, there should not be any wetting of the plaster, and nobody should write their messages like this. This is not a Taj Mahal wall or something. We Indians are very fond of writing our names for eternity on these historic monuments. Never do that. Keep it plain and simple till the fracture is united. So there is a surgery is also indicated in Colles fracture. It's not always so easy to get away with the closed reduction and treatment. Sometimes they may not listen to you, and we may need to go for surgery where high energy injury and instability. High energy injury may lead to a comminuted fracture where more than 2 or 3 fragments may be there, and that may lead to instability. So if there is instability at the fracture site, then you may need to go for surgical management. And intra-articular fractures, if they are displaced, then you need to put them back under vision so that secondary osteoarthritis can be avoided. And open injuries, as all of you know, that they are a different class altogether. These open fractures or compound fractures need to be tackled separately. If there is inclination, radial inclination, just remember this for now. We'll discuss these things later, and I may be able to show you some x-rays once you come back to the class. Then you will be easy for you to understand radial inclination. Then there is something called articular step off or gap if it is more than 2 mm, dorsal tilt more than 10 degrees, and distal radio-ulnar joint incongruity. If there is a instability at the distal radial ulnar joint, you cannot just leave it like that. You need to do something about it, and for that you need to choose the surgical management. And as always, whenever you fail in your closed reduction, then definitely you need to go for open reduction. So what are the surgical options here? The commonest procedure we do for Colles fracture as a surgery is percutaneous direct pinning. Most of you know that what is a pinning is all about. Pinning is by these K-wires. The K-wires, the ultimate weapon of the orthopedic surgeon. The K-wire, it's a very simple procedure, minimally invasive because we don't open the fracture site, we don't open the bone at all. We make a small nick here and just pass it. Okay, it prevents redisplacement because it is keeping the fragments in place. It provides stability, internal stability. That's why it will prevent displacement. Because displacement is prevented and fracture is stable, then the bone healing will be very, very good. And once the healing is good, then functional results will be definitely be good. And because there is no displacement, and after you remove the pins, the X-ray also looks very good. The ultimate problem for an orthopedic surgeon is post-operative X-ray, because any Tom, Dick and Harry can see the X-ray and can comment on the competence or lack of it of an orthopedic surgeon. So you can be radiologically be correct if you do the reduction and pass percutaneous pins. So they will most of the times they will lead to very good union and good functional result. Sometimes the simple K-wire may not be enough. So you may have to use what is known as a plate with screws. Yeah, definitely even here we do use plate and screws, and the plate can be on the dorsal side or volar side, but usually we put it prefer to put it on the volar side. Volar side, you put the plate and fix it with the screws, and the fracture goes to union, and you can easily put all the other joints into motion from day one. Ask the patient to move the fingers and everything, and joint unites very well. If you have a open fracture or a compound fracture, then it's a different ball game altogether, and here you need to resort to what is known as external fixation. Here there is no question of putting it a K-wires from inside and leaving it, because there is a wound, and the plate can also be avoided here, because this is open fractures. Here the external fixator can be spanning or non-spanning. What do you mean by spanning? Spanning means you have a joint here. This is radiocarpal joint and intercarpal joints, carpometacarpal joints. If you put your external fixator beyond this joint, beyond this wrist joint is fractured, but you put the pins beyond this wrist joint, so this means this is a spanning external fixator. So this spans the joint which is affected and beyond. So this is a spanning external fixator, and this external fixator is not spanning because all the pins are within this joint. It is not going beyond the joint. So if it goes beyond the joint, it is spanning. If it is not going beyond the joint, within the joint, this is non-spanning. If possible, non-spanning is always better, because once you put a pin beyond this joint, then all these will become stiff. There is a probability that these joints can go stiff. But there are some indications where if you want to give relaxation for the ligaments which are there, which are injured here, this is called a ligamentotaxis, where you this external fixator will do the function of the ligaments as well by going beyond the joint and giving stability to the joint. So this is called a spanning external fixator. This is a non-spanning one, and this is a clinical picture how an external fixator looks like for Colles fracture. And complications. So as in life, even in fractures, you will have lot of complications, and your ability lies in that your complications are very less and you get away with minimal or no complications. The early complications with every fracture, there may be a nerve injury, and the common nerve which may get injured may be a median nerve injury. A nerve injury or a vessel injury which may be there, or another one is called damage to the distal radioulnar joint. So this reflex sympathetic dystrophy should be here, and I think I corrected the slide, but the original one came back. Yeah. So the late complications are malunion, delayed union or non-union. Non-union are very rare because distal radius is a cancellous bone, and to get a non-union in a cancellous bone, it takes a lot of doing, and most of the orthopedic surgeons cannot get a non-union, and if you can get it, I think you are special. So don't try to get it. Usually it is delayed or malunion, most often malunion, and there may be stiffness if you are not careful to make the distal joints and proximal other joints which are not involved mobile, then you may have the stiffness. And the another important complication here in Colles fracture is rupture of the extensor pollicis longus tendon. So this tendon which helps wrist and the thumb may get ruptured because of the constant friction by the movements of the wrist. So you can get this. So you should have this in your mind to diagnose that once it happens. And another one, most important one, very rare complication, but if it is occurring, and this complication is both painful for the patient and the treating surgeon as well. So this is a short notes by itself. This is complex regional pain syndrome, previously known as Sudeck's osteodystrophy. When I was a medical student, we used to call it as a Sudeck's osteodystrophy. And as we go along, whether you get maturity or not, these terms keep changing because science is dynamic. So now we call this as complex regional pain syndrome. As the name itself indicates, it's a very complex thing and nobody knows clearly why and how it happens. And it's otherwise known as reflex sympathetic dystrophy syndrome. As the name itself indicates, it comes as a reflex thing and there will be an involvement of the sympathetic and there will be some dystrophy. So there are more than few things added in this, that's why it's a syndrome. Here what happens is the main pathology is many nerve impulses are sent to the affected site. Thereby there will be a dysfunction, and it could be a dysfunction in the central or peripheral nervous systems. And the healing process may sometimes be stopped or disrupted because of the excess nerve impulses. The person is not allowed to do his things. Lot of communications from above and he is confused and he is not doing anything. Same thing may happen here because that healing process is confused by the excess nerve impulses coming and disturbing it, and there will be a problem at the site. So there is another theory that it could be because of the disturbed immune process. So these are all the various theories why it occurs. So the main problem here is burning pain, severe pain in the whole of the limb for the patient, and swelling and stiffness of the affected joints, and there will be some motor disability. Because of the motor disability, patient will not move the joint or the affected body part, and along with that there are some sympathetic changes, because we have already seen. So the changes in the skin and the changes in the hair growth can also be seen. And sometimes the skin color may become blotchy, pale, purple. So many things can occur in this patient. A simple wrist fracture, and if you are unfortunate, your patient will have any of these things, and it is it's a hell for the patient as well as for you. So how to make a diagnosis? There is no single test or anything to diagnose it. It's usually a clinical diagnosis, and by process of elimination, then you need to diagnose this, because there is an initial injury is there, but sometimes the patient can complain that there is more pain, but you expect the pain to come down over a period of time. As the fracture is getting into second week, third week, the pain will come down definitely. But in these patients, the pain persists, and sometimes the pain will be more than initial period. And they change, if you open the plaster, and you can see the change in appearance of the skin and the hair and all. So here there is no definite cure. So all these things are like you are throwing stones in the fond hope that you are going to hit the bullseye. So you need psychotherapy for the patient as well as for the doctor, and physical therapy definitely helps, and topical systemic analgesics, narcotics if the pain is very, very severe. And there is a paper which describes that maybe anti-epileptics can help. We never know. And steroids and calcium and vitamin are definitely needed for fracture union. And sometimes the pain is very, very severe, we may resort to what is known as a sympathetic nerve block, or sometimes surgical sympathectomy also to be done in these patients. And on radiology, once you take the X-ray of the affected parts, you will see what is known as patchy osteoporosis. And patchy osteoporosis is the radiological finding in Sudeck's osteodystrophy or regional pain syndrome. This is, I think, an entrance bit. When I was preparing for entrance, whenever we used to say Sudeck's osteodystrophy, Colles fracture, old elderly females, sympathetic system involved, and patchy osteoporosis. These four things used to spring to our mind. So they need to spring to your mind whenever this regional pain syndrome is discussed. Coming to the Smith's fracture, here they say this is opposite to Colles fracture. Colles fracture, dorsal displacement. This is palmar displacement. Named after Dr. Smith, and this is called Gordon-Spade deformity. That is a dinner fork deformity, and this is Gordon-Spade deformity. And here usually surgery, we usually do surgery. Because neurovascular injuries are much more common here than when compared with Colles fracture, because the nerves and vessels are in close association with the displaced fragment here. That is Smith's for you. Coming to Barton, as we have already seen, there is an intra-articular element in Barton's fracture. If the fracture fragment displaces volarly, that is volar Barton, it is displaced dorsally, dorsal Barton. And volar Barton is always unstable. You cannot keep it stable. So that's why surgery always. Volar Barton, surgery always. Coming to the dorsal Barton, there is a place for conservative management sometimes. But usually nowadays, any Barton surgery, open reduction and internal fixation with plate and screws. This is about Barton's fracture. There is one more fracture called Schaffer's fracture. This is called Schaffer's fracture because in olden days the cars were used to be started by putting a starting handle and rotating vigorously. Usually the Schaffer does this, and if there is any, if it is slips, it used to hit his wrist, and this typical fracture used to occur, and this is called a Schaffer's fracture, or described by Hutchison, known as Hutchison fracture. And you should note that there is an entity called Schaffer's fracture, which is an intra-articular fracture. So whenever somebody says intra-articular, then I think your ear should be pricked and your antenna should be awake, so that it should be fixed as far as possible. So there should not be any deformity in the joint line, which will lead to secondary osteoarthritis. Another type of fracture, these are all for completion sake, but you never know, you may get this as a short notes. This was a short notes during one of the UG examinations. Die punch. Here it's like a punch where there is a depressed fracture in the articular area of the lunate fossa, because the distal radius articulates with scaphoid, lunate and triquetrum partly. So this, if the lunate acts as a die and punches the radius and leads to a depressed fracture. Another most important fracture in the distal part of the wrist is a scaphoid fracture. All of you know that scaphoid is one of the carpal bones. So you all know a proximal row and a distal row, and a mnemonic to remember all these things. Scaphoid, lunate, triquetrum and pisiform, they form the proximal row of carpal bones. The most common carpal bone to get fractured is scaphoid. So why I am again and again stressing these things is this helps you in the PG preparation as well. So by one class I am trying to prepare you for UG as well as PG entrance examinations. Okay, so scaphoid is the most common carpal bone to get fractured. And how do you clinically make out that this is a scaphoid fracture? The fullness in the anatomical snuff box. This is called an anatomical snuff box. The area on the dorsum of the hand, in between these two tendons, there is a box-like structure. All of you can verify that. Maybe previously they used to put snuff here and used to inhale. Previously this finely ground tobacco powder they used to inhale, and nowadays we see a lot of people inhaling white powder. We don't go into that details, but this is called anatomic snuff box. If there is a fullness and if there is a tenderness here and if there is a history of fall, then you can clinically make a diagnosis of scaphoid fracture, and on X-ray you can clearly see the X-ray of the wrist showing the fracture line here. And scaphoid is very important in that its blood supply is a bit different. Usually in most of the bones, the blood supply comes from proximal to distal. But here, this radial artery, even though it is coming proximally here, it did not give any branch here. Instead, it went distally, and from there it has given branches. So this proximal part is not very well supplied by the blood supply. So if there is a fracture here, then there will be disturbance to the blood supply to the proximal part. So whenever there is a fracture and whenever there is a disruption in the blood supply, then the proximal part of the scaphoid will go into what is known as aseptic necrosis. Aseptic necrosis. So that's why scaphoid fracture is very, very important for you. Once this goes into aseptic necrosis or a vascular necrosis, then the wrist joint becomes a very, very painful joint and the function is lost here. So how do you treat a scaphoid fracture? Usually by conservative management, a cast immobilization. You have seen this cast. This is a separate cast when seen along with the Colles fracture. Here you keep the hand in what is known as a glass holding position. That means a dorsiflexion and something like this, and you put the plaster in this way and keep it for 6 weeks. Take a check X-ray and if possible keep it for another 2 weeks. So minimum 8 weeks for scaphoid fracture, and if it is the fracture is displaced, then you need to go in for open reduction and internal fixation, especially by means of a screw. And this screw is special in that it has no head. This is headless like most of us. So this is a headless screw, and which is used for fixation of the scaphoid fractures. Hubbard's screw, it's called Hubbard's screw, and this is used to fix the scaphoid fractures. And what are the other indications for open reduction and internal fixation of the scaphoids? A displaced fracture and a non-union. a non-union is a painful process. So whenever there is a non-union of the scaphoid, you put some bone graft to augment the bony union and fix a screw to make it more stable. Okay. Why scaphoid is important? So you can see there is a fracture there and it was not treated properly, and the whole this proximal fragment, it has gone, it has become into a vascular part. You can see it is seen as a white structure here when compared with the other carpal bones. So this is one of the problems with scaphoid. Scaphoid, it's not easy. So avascular necrosis and non-union are always threats in scaphoid fractures, and once this articular margin is destroyed here or here, then it will lead to secondary osteoarthritis. And there is one more word in passing while finishing the class. So there are some areas where this avascular necrosis is very, very common. So all of you should remember these areas, and whenever there are some fractures, if you don't remember anything else, you can write avascular necrosis as one of the complications. The main fractures where this can be seen is fracture neck of femur. Fracture neck of femur is one where you will find this avascular necrosis. This is the avascular area, and scaphoid fracture. And another fracture which is akin to scaphoid, the bone in the foot which is akin to scaphoid is talus. So talus also you will find avascular necrosis because of its peculiar blood supply. Even here it is because of the peculiar blood supply. So we will go into those things in detail when you discuss those things. And even in humerus, sometimes you may have a necrotic area because of the loss of blood supply, and which will lead to avascular necrosis. So these are some of the areas where this avascular necrosis is quite common. So whenever a fracture occurs in these areas, you should be more than careful to see that your management is proper and your treatment is adequate to prevent this complication. Thank you very much for your patient listening, and if there are any questions, you can always send through my WhatsApp.